Welcome to Breakdown. This is our new season of the ER and hospital journey. So, have you ever been stuck in an ER waiting room, just watching the clock tick by, wondering what on earth is going on? Well, today we're going to follow that exact patient journey to understand why our emergency rooms get so incredibly backed up. We're putting you right in the shoes of a patient walking into a busy ER to uncover the real story behind those wait times. And hey, for all you first responders listening, this is a look behind the curtain at the system you deal with day in and day out. All right, so you walk through those automatic doors. Your journey begins right there, with a really critical first step called triage. Let's get into it. Now, if you're the patient, this part can feel, well, kind of confusing. You might have been sitting there for a bit, and then someone who just came in gets whisked to the back. That's because the ER isn't first come, first served. It's all about a super fast assessment to find the sickest patients first. And for medics and EMTs, this is where your handover report is absolutely crucial. The info you give that triage nurse feeds directly into this whole sorting process. You know, triage has really evolved. Historically, a lot of ERs used a pretty basic three-level system. They'd just sort people into simple categories like emergent, urgent, or non-urgent. But, well, researchers found a pretty big flaw with that approach. The problem was that middle urgent category became this giant catch-all bucket. It made it really hard to tell the difference between someone who is seriously ill and someone with a more minor issue. So the big takeaway here is that the modern five-level systems we see today are just way, way better at flagging the highest risk patients. It's how we make sure someone with chest pain gets seen before someone with a simple rash. It's just safer for everyone. Okay, so you've been triaged. If you're not in that top critical category, you're now in the waiting room. And this is where that feeling of complete gridlock really starts to set in. It's all driven by a massive, system-wide problem called crowding. Crowding isn't just a full waiting room, not at all. It means the entire department is stretched to its absolute limit. Not enough beds, not enough staff, not enough resources to care for people the way they need to be cared for. But what's really fascinating is that this isn't just an ER problem. That quote from the American College of Emergency Physicians, it just says it all, doesn't it? The ER is just the tip of the iceberg. The real problem is that the entire hospital is full, and that leads to this dangerous bottleneck that we call boarding. So picture this. You've been seen by a doctor, you've got a diagnosis, and they say, "Yep, we need to admit you to the hospital." Great, but there are no beds available upstairs. So now you're boarding in the ER. You're officially an admitted patient, but you're physically stuck in a hallway or a noisy corner. Hey, first responders, this is the reason you're stuck on wall time waiting for your stretcher. It's not the ER's fault, it's a hospital-wide traffic jam. And let me be clear, boarding isn't just some inconvenience. It has severe, well-documented consequences. For that patient stuck on a gurney in a loud hallway, it's not just uncomfortable, it's downright dangerous. Studies have directly linked crowding and boarding to more medical errors, worse pain management, and even higher death rates in the hospital. And this one stat just blows my mind. It shows how the whole system just grinds to a halt. One study looked at the turnaround time for a troponin lab test. That's the critical test for a heart attack. What they find? For every 100% increase in the number of boarding patients, the average time to get that vital lab result back went up by over 32 minutes, a half-hour delay for a life-threatening condition, all because of a traffic jam inside the hospital. So if the ER backup is the symptom, what's the disease? We have to look at the root causes of this massive system-wide logjam. This problem has been brewing for decades. Just look at these numbers. Since 1975, the number of hospital beds in the US has dropped by a third. And during that same time, the population has grown and annual ER visits have absolutely skyrocketed from less than 100 million to way over 130 million. It's really simple when you think about it. We have way more people needing care in a system with far fewer places to put them. That mismatch between supply and demand is a huge driver. But there's another major factor: the immense strain caused by the lack of resources for patients with behavioral health needs. So at the exact same time the general population was growing like crazy, the country lost more than half of its mental health beds. With nowhere else to turn, patients in a mental health crisis often have no choice but to go to the ER. And once they're there, studies show they can wait almost 3 times longer than other patients just to find a proper bed or placement. Okay, so this problem of an overcapacity system seems huge. But the good news is there are proven high-impact solutions, and they all focus on 3 key areas: decreasing the input, improving throughput, and increasing the output.
Let's start with input. The big idea here is to help people get the right level of care in the right place so they don't automatically default to the ER for every single problem.
And some of these ideas are surprisingly simple. Things like publicly posting wait times or even offering scheduled appointments for less urgent problems can make a huge difference. In fact, a study in Britain found that up to 26% of ER visits happened just because people couldn't get in to see their primary care doctor. Better access there means way less pressure on the ER.
All right, next up is throughput. This is all about making the flow inside the ER itself way more efficient.
This is all about smart logistics. So instead of a patient waiting in line for triage, then another line for registration, then waiting for a room, some ERs use what's called direct bedding. A nurse and a registration clerk meet you right at the bedside and do everything at once in parallel. Another game changer is fully using advanced practice providers, that's nurse practitioners and physician assistants, to see patients and get the ball rolling much faster.
And finally, we get to output. Honestly, this is the big one. This is about fixing that boarding problem by getting admitted patients out of the ER and upstairs faster. Hospitals can use strategies like having a bed czar, a single person whose only job is to manage every single bed in the hospital, or using a discharge lounge for patients who are ready to go home but are just waiting for a ride. These aren't just theories. These strategies have been proven to slash ER wait times and the hours that ambulances have to be diverted. Which really brings us to the final, most important point. That long, frustrating wait you experience in the ER, it's not an ER problem. The ER is just the canary in the coal mine. It's the flashing red light signaling a much bigger issue, system-wide capacity. The key takeaway is this. Fixing the wait means fixing the entire patient journey. From making sure people can see a family doctor, all the way to ensuring there's a hospital bed ready when they need one. So the real question is our healthcare system actually designed for the reality of today's needs?